Before starting the procedure, ensure that all necessary equipment and supplies are ready and covered before the patient enters the room to reduce anxiety. When the patient enters the room, confirm her identity and check whether a consent form has been signed, review her medical history, and whether contraception options have been discussed. Introduce yourself and any other staff in the room and briefly outline what their roles are. During the procedure, continue to assess her level of comfort and be open to pausing anytime the procedure if she is not comfortable. Further pain relief options can be discussed and administered during the procedure if required, but remember to follow local protocols if conscious sedation is considered. When the woman is comfortable on the couch, the first thing to do is to check the position and size of the uterus with a bimanual examination. If there is any doubt about pregnancy dating, an ultrasound scan can be carried out, if available. Secondly, insert the Cusco speculum and check the cervix for any signs of infection. Then clean the cervix with antiseptic solution from the os to the edge of the vagina. If a Parasitical Block is chosen, this is performed as follows. Inject 1 to 2 milliliters of local anesthetic at the cervix where the tenaculum will be placed, either at 12 o'clock or 6 o'clock, depending on your preference. Stabilize the cervix with the tenaculum. Use slight traction to move the cervix and define the transition of the cervical epithelium to vaginal one. This delineates the sites for next injections. Slowly inject 2 to 5 milliliters lidocaine into a depth of 1.5 to 3 centimeters at 2-4 points at the cervical vaginal junction. It can be done at 4 and 8 o'clock, for example. Move the needle while injecting or aspirate before injecting to avoid intravascular injection. The maximum dose of lidocaine in a Parasitical Block is 200 to 300 milligrams, approximately 20 milliliters of 1% solution or 40 milliliters of 0.5% solution. During the uterine aspiration procedure, a no-touch technique should be observed. Any instrument that enters the uterus should not touch surfaces that are not sterile, including the vagina walls and other parts of the reproductive tract. With the speculum still in place and after Parasitical Block, apply gentle traction with the tenaculum to straighten the cervical canal. If you need cervical dilation, you can use Denniston dilators or the cannula. Introduce the size 5 cannula gently through the cervical os into the uterine cavity. Advance the cannula slowly until it touches the uterus fundus, then withdraw it slightly. Rotating the cannula with gentle pressure can ease insertion. Repeat this with progressively larger cannula until you reach the size that is appropriate to the patient's gestation, as follows in this table. For the uterine size, which corresponds to 4 to 6 weeks since LMP, you can use cannula size 4 to 7. For the uterine size 7 to 9 weeks, you can use cannula size 5 to 10. For the uterine size 9 to 12 weeks, you can use cannula size 8 to 12. And for uterine size corresponding to 12 to 14 weeks, you can use cannula size 10 to 12. It is critical to insert the cannula gently through the cervix. A forceful movement of the cannula increases the risk of trauma of the cervix and the uterus or the surrounding pelvic organs. Attach the cannula with the adapter, if required, to the prepared aspirator, which has the vacuum already established. Do this by grasping the cannula firmly at the base with one hand, holding it steady. Make sure that the cannula does not move forward into the uterus as you attach the aspirator. With the other hand, hold the aspirator by the valve body. Release the buttons of the aspirators to transfer the vacuum through the cannula into the uterus. Blood, tissue, bubbles should begin to flow through the cannula into the aspirator. Evacuate the content of the uterus by rotating the aspirator 180 degrees in each direction. while using a gentle in and out motion to cover all the surfaces of the uterine cavity. If the aspirator fills up 2/3 and causes the suction to stop, depress the valve button or buttons and disconnect the cannula from the aspirator. Leave the cannula in place in the uterus and either replace the aspirator or empty its content before reattaching it to the cannula. If the cannula becomes clogged, move it over the cervical os, but not through it. This movement will often unclog the cannula. If this does not work, depress the valve button or buttons and disconnect the cannula from the aspirator and remove it from the uterus, taking care to prevent contamination. Alternatively, withdraw the cannula and the aspirator together with depressing the button or buttons. Remove the tissue which was clogging the cannula with sterile forceps. Re-establish vacuum in the aspirator. Reinsert the cannula using the no-touch technique and continue the procedure if required. Never try to unclog the cannula by pushing the plunger back into the cylinder. The signs that the uterus is empty include a red or pink foam without tissue that is seen passing through the cannula and a gritty sensation that is felt as the cannula part is touching the surfaces of the uterus and the uterus contracts around the cannula. When you have established that the uterus is empty, depress the valve button or buttons and remove the cannula from the uterus. Alternatively, withdraw the cannula and aspirator together without pressing the button or buttons and disconnect the cannula from the aspirator. You can also leave the cannula inside the uterus until you do the tissue inspection. Empty the content of the aspirator into the appropriate container by releasing the buttons, squeezing the plunger arms, and pushing the plunger fully in the cylinder. Inspection of the product of conception is important to ensure a complete abortion. To inspect the tissue, empty the uterine aspirate into an appropriate container. Look for the quantity and presence of the product of conception, like villi, deciduum, and sac, in appropriate quantities based on gestational age. After 9-week gestation, fetal parts are visible. The presence of grape-like hydropic villi may suggest a molar pregnancy. Abnormal findings should be sent to the pathology laboratory. If no products of conception are visible, less tissue than expected was removed from the uterus, or the tissue sample is inconclusive, this may indicate the following: a failed abortion when all product of conception remain in the uterus. Incomplete abortion, the uterine cavity still contains some product of conception, even if it appeared to be empty at the end of the procedure. A spontaneous abortion that completed prior to the procedure, or an ectopic pregnancy, and this should be further investigated. If you are not absolutely sure that the sac and villi are present on tissue evaluation, re-aspiration should be done. When the products of conception have been checked, dispose them as per your local guidelines. Before removing the speculum, insert intrauterine contraception device or intrauterine system if this has been agreed. Remove the tenaculum and make sure there is no ongoing bleeding. Help patient up, escort her to the recovery, and reassure that the procedure is finished. Document the procedure, clearly entering details of the patient, date, time, findings of the tissue examination, details of the procedure, and any difficulties encountered.